We've had just tons of, bias and stigma in our world as we've learned that obesity itself is a complex medical condition, as complex as, say, cancer or the multitude of different cancers we have.
Dr. Palmer.
Dr. Jerkins.
How's it going?
It's going very well. Oh, man, come on. I was going to do a bit. Nope, I lost it. Okay.
You have something witty.
I have something witty. How about this? Can we just splice in a something witty here?
I don't know if that's how it works.
Is that not how it works?
Yeah.
Some pithy aphorism or something?
I don't think I've ever used the word pithy in the conversation. I should. Maybe that's a goal.
I think there's enough time left that you could work this in.
Well, I think today's topic is very interesting. Not only is it interesting, but also I would argue this is probably the nation's leading expert on obesity medicine that we have with Dr. Angela Fitch. I have a lot of questions, and I know, Ned, you probably have a lot of questions you want me to ask, but we are excited to have Dr. Fitch on. I've known her, and you've known her for a long time. Very well published, she's a leading thought expert on obesity medicine. And look, I don't know about you, Ned, but I have a lot of patients ask me questions related to this topic based on information they got on TikTok or Twitter or a friend or a cousin. So it's really nice to have someone like her that's kind of a focus now in the last couple of years, but she's been doing this for a couple of decades. So she brings this wealth of knowledge and experience to the conversation.
Yeah. I would say it's kind of incredible to be able to talk to one of the nation's leading experts in what is still continuing from a demographic standpoint to be one of the leading epidemics or pandemics that we're dealing with across the country from a non-communicable disease standpoint. So, like you said, we've known Dr. Fitch for a long time. She was actually my preceptor when I was in resident clinic way back when. And so she's seen me from when I was a very bad outpatient doctor in my first year of residency till now. So, it's incredible to get to talk to her about what can actionably be done about obesity. That's for primary care doctors. She talks about it from the inpatient side. She really talks about it from the surgical side, like really how obesity needs to be managed, which is, we know, multimodal therapy, continued, long-term progress and pressure applied to try to make improvements. It really is a very difficult chronic disease to manage. I loved her very practical approach and pragmatic approach at different care delivery phases.
Yeah. So I have a lot of questions on all of that related to not just how we do it, but also kind of macro. What are some factors that are influencing how we can do this at scale? And I think every conversation I've had with a patient about pharmacologic therapy for obesity, it's always about access and cost, which I think is appropriate to some degree, but it becomes the driving factor, not what's medically appropriate, but what is available based on where they live and what kind of insurance they have, et cetera. So there's a lot of questions I have on that. I look forward to asking her, and maybe let's just cut to it with Dr. Angela Fitch.
We are pleased today to have Dr. Angela Fitch, who is the co-founder and chief medical officer at Knownwell and immediate past president of the Obesity Medicine Association. She is she's board certified in internal medicine, pediatrics, and obesity medicine, and has been practicing obesity medicine for over 15 years. She is an international expert in obesity treatment, and she currently provides comprehensive obesity care to patients of all ages at Knownwell as they develop the first of its kind patient-centered medical home for people with obesity and metabolic health concerns. Also, I think this is a fun fact of Dr. Fitch. She was the first person ever to interview me for a real job after residency. It's a fun fact. But Dr. Fitch, welcome to the show.
Thank you so much. Thanks for having me.
Yeah, we're very excited. We have lots of questions and things to get into today, but I think it would be very interesting for our doctor audience to understand a little bit about your story and why you chose to really pursue this pathway in obesity medicine.
Yeah, well, I actually was my undergraduate degree was in chemical engineering. So I was always super passionate about metabolism and like how does the human body, work as an engineering organism, so to speak. I thought about going to graduate school. I thought about going to medical school. I ended up going and getting a job after medical school, before I went, or after undergrad, before I went to medical school. And so I think I've always just been super impressed with, metabolically, how does the human body function, right? And then as I got into primary care and doing primary care, so many patients were coming in, they're like, well, how do I lose weight? And I'm like, I don't know. No one taught us how to do that in medical school. Like, I mean, we were dealing with, people in septic shock and all sorts of other, conditions, right? I mean, but losing weight was always one of those big mysteries, right? And it was always like this eat less, exercise more, right? Or, go do this program or, and I was always amazed how it was always just put off onto the patient, right? Like, the patient had to pay for it. The patient had to go to some place, or some program or some app, and it was always something that was just sort of, thrown upon the patient, to be responsible for. And because of that, we've had just tons of, bias and stigma in our world as we've learned that obesity itself is a complex medical condition, many, as complex as, say, cancer or the multitude of different cancers we have, right? We actually have multitude of obesities. We don't think all obesity is even the same. So, scientifically. So I think, the science has changed, and the rest of the training world and the treatment world is now catching up.
Yeah, that's interesting because you are, I think, a pretty big trailblazer in this movement, especially integrating the different modalities of treatment for patients with obesity and a more integrated approach. Is that right? I mean, just your role and its progression and development over the years, you've had a pretty integral part of that.
Yeah, so I was one of the first people to get board certified in obesity medicine back in 2012. I was waiting for the board certification to sort of come out, essentially. I had an interest, I was busy in primary care, 3,500 patient panel as an outpatient in a very progressive health system in Minnesota, which was very, fortunate for me at the time. I didn't realize it. I thought I was just taking my first job, but I was working in a care team. We had a pharmacist embedded who was doing, pharmacy med management for us, and we had chronic disease managers, and we had, we were doing virtual visits back in 2005. So there was actually virtual care, a long time ago, despite the fact that everybody thinks it's new. And so we were doing telemedicine, before telemedicine was cool. And it was just like that for us in Minnesota. We were innovating on healthcare delivery. And we realized it at the time. We had a $3 million grant. This was back in, like I said, the early 2000s. So $3 million back in 2010, essentially. So someone, do that math as to what that is today. But we were given this grant to sort of redesign primary care. And out of that, came this sort of also, like I said, as I was developing my love for doing weight management and helping people to understand that, there was really no obesity medicine fellowships. We have them today, but back in my day, it was just, I went and shadowed people at the University of Minnesota who were doing this work, shadowed the bariatric surgeons, went to the bariatric surgeon case conference and sat in and listened to the struggles of people with obesity and how it was being treated, and sort of, then got board certified in 2012. And then I transitioned over to doing mostly large academic weight center type work, building these weight centers that live within large health systems or large academic centers, combined, medical, surgical, comprehensive care. And now I'm trying to bring that out to scale, to the public, right? Or to the, to everyone, right? Because, when I left Mass General, I was at the Massachusetts General Hospital Weight Center most recently as the co-director there. And that's a 20-year-old weight center. So it was very pivotal. It was very, it was innovative of its time when it developed 20 years ago as a comprehensive weight center. And when I left Mass General a couple of years ago to start Knownwell, we had 5,000 people waiting for appointments. This was 2 or 3 years ago. Okay. 5,000 people waiting before everybody knew about GLP-1s. I mean, this was when people would come in and they would come to see us for expert care, but we'd have to kind of talk them into, utilizing the tools we have in our toolbox. Like, it wasn't like now. I think more patients are coming in saying, I want treatment. Right? Because treatment was so stigmatized before. It was kind of like, well, I think I can do this on my own if you just teach me how to eat better and exercise better. And I'm like, well, you've done that like 8 times already in your lifetime and hasn't really worked, has it? People would be like, yeah, I guess it really hasn't, but you got something different, right? And I'm like, no, don't have anything different. I mean, not from a lifestyle standpoint, right? I mean, there's all these lifestyles that develop to try to be something different, right? There's keto, there's whatever, there's all these different, lifestyles that people can live into, and none of them are wrong. But the point is that lifestyle alone is not really enough to treat a disease state. It's never been enough to treat a disease state as we look at diseases, right? I mean, lifestyle is not enough to treat heart disease, right? We need angiograms, we need caths, we need, valve replacements, we need surgery, we need these interventions. We don't have to do those interventions. We can die of a heart disease earlier, like we used to in the 1930s, but we've developed these interventions because they help us live longer and treat the disease state that happens, right? And that's what we're getting to now with obesity, where I think people are recognizing that it's not just a lifestyle intervention alone, that it's actually a combination between lifestyle intervention and medication and surgery and procedures now that are coming about as well, non-surgical procedures too. So, I mean, it really is a pivotal time right now to be able to scale treatment and get it out to people, in a longitudinal fashion too. I think that's really key. We've never treated obesity as a chronic disease, and that is really what it is, a chronic disease. And we have got to recognize that as both patients with obesity and also as, care providers for people with obesity, because it's not go get it fixed and then you're done.
I mean, it's interesting you say, just with your history in this field, can you talk to us a little bit about how at least the pharmacologic therapies have changed even over the last, couple of decades? Been pretty intense over the last 4 or 5 years, of course. But even I have patients asking me about medicines that were recalled, in the early 2000s or the 90s, and there's new medicines now. Talk to us a little bit about how the medications have evolved over time to treat this disease.
Well, certainly and again, back, 20 years ago, we had GLP-1, right? I mean, GLP-1 also isn't new. I mean, for those of us that have been, in practice that long, I mean, we were the first group in the country at the University of Minnesota to do a pilot study of adolescents. So these are adolescents with obesity. Back in 2010, we did a study with Byetta, which is the first GLP-1 that we had on the market. You had to take it twice a day. You had to take it within 30 minutes before you ate. Otherwise, if you took it too late, you would decrease your gastric emptying, and then you'd be getting sick while you're eating, right? So you had to time it perfectly, right? So you're talking about giving yourself an injection twice a day, which is never very successful for people to take anything twice a day, let alone an injection twice a day. But we piloted that in adolescents, back in the early days, and it wasn't until much later where we had our first GLP-1, which is Saxenda, that was available for adolescents. It took, over 10 years before, when we did that first study of GLP-1, way back then, it took 10 years before we had a GLP-1 that was actually FDA approved for adolescent obesity. And like, for example, when to correlate that, when the HIV epidemic hit, it only took 3 years before AZT was approved for pediatrics, because there was this, recognition that this was, transmitted, right? Maternal fetal transmission, and we needed some treatment for these kids because, we needed to be able to, stop that from happening, et cetera. But that same urgency didn't exist, even for our adolescents with obesity back then, right? Like, you would have thought that had we had data to show that this was an effective treatment for those kids, and this wasn't even a very effective GLP-1. I mean, Byetta was not very effective. Yet at the same time, it took 10 years before, that came, that it seemed that important, right, to get it out there. So there's just there's been such this, as we develop GLP-1 in particular, and now all the other, what we call NUSHs, right, nutrient stimulating hormones that are coming out, as we've understood the pathophysiology of obesity and obesity treatment, it's really helped to advance, that pharmacologic therapy. And then the drugs have just gotten so much better. I mean, is the reality, from an efficacy standpoint.
And I will say in training, like we weren't prescribing a lot of these medicines for patients with obesity, mainly at that time because a lot of our patients couldn't access them anyway. We, of course, learned about them, but my experience with actually prescribing medications and walking patients through these medications really happened afterwards. And I don't know if a lot of other training programs have faced that struggle where they have a patient population that can't really get coverage for these medicines. So there's a lack of experience in prescribing. I don't know if that's something you've reached or you've seen.
Yeah, but there's also our generic medications, right? I mean, our medications that are generic today, or our older medications such as phentermine, topiramate. We've had decent treatment for obesity. So I'm, as the immediate past president of the Obesity Medicine Association, the Obesity Medicine Association is a group, is there for all of your listeners who are clinicians, right? Whether you're if anyone who's working in the field of obesity can certainly join the Obesity Medicine Association. We're there to support the clinicians, right? We're the association to support the clinicians, much like the American College of Physicians or other types of, clinician groups that we have to be members of. Well, the OMA, the Obesity Medicine Association, was started in 1950. 1950. So we have had effective treatment for obesity for a while, but it wasn't near as effective as it is today. So if you look at the data, this is what's really critical for people to understand. When you look at 20% weight loss, like getting a 20% weight loss for a patient, and when you think about that, that's really not, quote unquote, that much weight, meaning from a patient expectation standpoint. Because a patient who's 250 pounds, 20% is a 50-pound weight loss. They think they can do that tomorrow with some sort of app on their phone, right? I mean, most patients come in thinking, oh, I can lose 50 pounds. Like, I mean, the cover of People magazine said that to me, on the way out the supermarket. I lost 50 pounds on the soup diet, or, whatever the case may be, right? So there's this unrealistic expectation of human metabolism that we can just shed 20% of our weight and keep it off. So a lot of people can lose that 20%, but the data shows, the overwhelming studies show that even if you can lose that 20%, that over the course of the next 8 years, you're going to gain the majority of that back. Okay. And so the thing is that this ability of the human body to lose weight and then maintain weight loss is very underappreciated, so to speak, right? Or overappreciated, and so again, we've had effective medications, but if you look at 20% weight loss, our newer medications, such as semaglutide, which was our first, what I would consider highly effective anti-obesity medications. That's the terminology we're using now today to describe these newer medications. 40% of people are able to achieve a 20% weight loss with that treatment. Okay. If you look at phentermine, topiramate, those numbers are about 20% of people. So we used to be able to get, 15 to 20% of people into that 20% weight loss category. All right. Now we're getting 40% of people into that 20% weight loss category. And with tirzepatide, which is our newest molecule, right, which is a dual agonist. So it's activating two of these nutrient stimulating hormones, it's activating two of these receptors. With tirzepatide, 60% of people are able to get into the 20% weight loss category. Now you have to recognize as well, surgery helps about 80 to even close to 90% of people get into the 20% weight loss category. Right. But yet we also haven't had a healthcare system that sort of understood this basic concept of how hard it is to lose 20% of your weight, right, and keep it off. And the advantages of that, too, as we look at, the reason I'm talking about 20% and not 5%, we've always focused on 5 to 10% because that's good for prevention of diseases like diabetes, et cetera. But when you get greater than 10% and into the 20s, you're talking about prevention of cardiovascular disease. You're talking about extended life expectancy. You're talking about getting rid of sleep apnea, hypertension, fatty liver disease, diabetes, right? Diabetes remission. So the more weight loss you can get, the more you can get people out of some of these other comorbidities, right? And that's why that 20% is even more important. I mean, it's great if someone loses 5% of their weight and keeps it off for the rest of their life with a lifestyle intervention. That's a huge accomplishment for them, and they should be commended for that. But at the same time, most people don't get commended for that, right? I mean, the world doesn't tell them that that's a huge accomplishment, right? And that they should spend half of my time really in practice sort of telling people how good they're doing and how they should just, keep it up because what they have done is something that most people can't do, right? And again, if you go back to that data, I have this table that shows this in my talks I give that shows this sort of 20% weight loss, right? Only about 5% of people are able to lose 20% of their weight with a lifestyle intervention program. There are people that have done it. You've talked to them, you've met them, you probably know them. You might be one of them if you're listening. Well, gosh, I did it. And all I did was, change my carbs and counted my calories. And I worked out on my Peloton and I went for walks every day. I mean, there are people that do it, but it's 5%. It's not the majority, right? It's the minority. And that's where we have to come to this realization nationally and understand that this is a disease that's worthy of treatment.
And I have found managing those expectations with patients now even harder with videos on TikTok or all of the stories about celebrities being on whatever medication that somebody prescribed them. It's really difficult to fight that information, to set realistic expectations, and to get buy-in so that we develop a healthy relationship when we're treating this disease.
And understanding that you have to do it forever. And because again, I think the biggest problem we have today, unfortunately, is we've let the cat out of the bag in a good way. We should have more people getting treatment for sure. But if treatment is episodic and patients gain weight back, they actually are sicker than if they didn't gain the weight back. So people need to understand there needs to be a huge public service announcement that treatment of your obesity is a chronic disease treatment process that you need to have a care partner in your, court, which, ideally the primary care physician is the ideal person to deliver that, right? Because that's what we're designed for, is to be there for you, forever, right? And the thing is that if you lose weight and gain it back, your metabolism is not the same as it was when your weight was higher before. And so when you gain weight back, you tend to gain more fat mass back than you gain lean mass back. And then your metabolic rate is slower. So for example, if you were 250 pounds and you lost, your 50 pounds, your metabolic rate, let's say when you were initially 250 was like 2,000 calories a day. Like if you ate 2,000 calories a day, that would keep you at 250, right? But when you gain that weight back after losing it, however you lose it, whether you lose it with a diet and exercise program or you lose it with medication or surgery or however, when you gain that weight back, you now, instead of burning 2,000 calories at 250 pounds, you're burning 1,700 calories at 250 pounds. So you're in a 300 calorie deficit to start with. You see what I mean? So you have to get then even lower to go down again, which is why people will say to you, well, I lost it this time or that time, but now it's harder. I can't lose it. Like it's harder to lose this time when I gained it back, right? So that's why we have to be really serious about this. Is not medicine. These are not drugs we should be able to buy out of the back of a van and self-medicate with. I mean, there's a reason we have an FDA and a process for this, with prescribing and doctors and things, right? Because this is not something to mess around with. Your metabolism is not, Mother Nature is not something to mess around with.
Yes. And that's a good point. I think I have heard you speak other places on this topic, and I'm excited to hear you talk about it, is given that it can be very hard for insurance to cover the new medications, which I think last I looked, for instance, there was only 4 state Medicaid programs that covered weight loss medication.
No, there's we're up to 16.
Oh, wow. My numbers are quite different. Apologies. A small minority, though.
No worries. There was just a recent publication on this. The Stop Obesity Alliance just published a nice publication, highlighting, because they did the research, because it takes a lot to do the research. It's hard to know how many, because it's not really,
They don't broadcast it.
Yeah, which is, again, this is bad, I think, right? Again, this is part of the bias and stigma of the disease state, right? It should be the real issue we have in the United States of America today is that obesity is not a standard benefit on your health policy. It is a carve out, just like the only other carve out we have in healthcare is infertility treatment. So infertility care and obesity care are not standard benefits on your health insurance policy. The reason for that is they were considered at one point in time, way back in the day, to be sort of elective things, right? Like, in other words, if you were an employer that wanted to offer those types of treatments, you would add them on as coverage because, again, they were considered, things that weren't necessary, right? Weren't critical. They weren't a standard benefit on our healthcare plan. But to say that about obesity today, that's what we try to push back against, is that it shouldn't be an elective type of additionary benefit that you add to your health plan. It shouldn't be that our health insurance companies in our country can make billions of dollars a quarter financially in profit as for-profit companies, and at the same time we don't cover the largest pandemic of our country. And when I say cover, that doesn't mean everybody needs $1,000 medication, or it doesn't mean we can afford to give everybody $1,000 medication a month. It doesn't mean that. We can't afford that. We have data on that. But we can afford to give some people that $1,000, and that's what we need, medication a month, right? And that's what we need to be trying to figure out as a society, is how are we going to manage that until the cost of these medications come down. I firmly believe that the costs will come down, and we will be having this discussion, and we'll be like, we'll look back on this podcast and we're like, remember when we talked about that?
Well, I can't wait for that, because actually, so going back real quick, so a minority of states' Medicaid programs cover weight loss medications. Medicare does not cover weight loss medications, at least right now.
Soon, hopefully.
That's what I was going to ask you. So give us the update on that, because my understanding is this has been on the docket for like a decade or so, right?
12 years, because I've been to Capitol Hill. For 12 years, I've been going to Capitol Hill, sitting in various senators' offices and, trying to lobby, again, for the Treat and Reduce Obesity Act, which has been before Congress for a long time. If you remember the Schoolhouse Rock, it might be before your time. But
no, I do. I remember.
I'm just a bill. Yes, I'm only a bill. He's sitting on Capitol Hill. And then, he was finally, he's off to committee, right? So, the good news is that it went off to committee finally. It finally made it to committee. And it just passed through the Ways and Means Committee. So it's made it as far as it's ever made it before. We're very hopeful that because of some of the research that's come out, especially around cardiovascular disease risk reduction, and, it's going to get very hard for us to not take care of obesity as a standard benefit, meaning when you get all these drugs being approved for sleep apnea, you just saw maybe the tirzepatide data with sleep apnea, and we have data for semaglutide with kidney disease and fatty liver disease. And, so if these drugs, all these companies are doing these studies in these drugs to get indications for them, because they have an indication for obesity, but obesity is not covered. So can you imagine the fact that we spent, we need the data on, we need the science on the fact that it improves sleep apnea, right? For example, but look at the millions of dollars we've spent in clinical trials that could have actually gotten medications to patients. If we would treat obesity, they're doing these studies because they want to get an indication for sleep apnea because they know that obesity is not covered.
Explain. It's such a huge deal if Medicare does cover these medicines. And will you explain it to our audience of how that affects everybody, even if you're not on Medicare?
Well, I think the hope is that if the Treat and Reduce Obesity Act passes, that then it will be that it'll be hard for the commercial insurance, the private insurance, to still carve it out. That if we consider obesity care as standard, that's one of the arguments we've heard in the past. Why? when I was president of the OMA, one of my goals, which I did not accomplish, was I had this beautiful dream that I would bring together all the commercial insurers and we would all get in the room and just do the right thing, which is just to say, obesity is a standard benefit. No one has to pay extra anymore for coverage. And I think you shouldn't have to pay extra for coverage, right? You still have to manage your medication spend cost, right? I mean, to me, that's a different problem than just saying it's covered, because, Qsymia, Contrave, they're $99 a month. They're not expensive, as relative to other medications, and that's the cash price. So I'm sure, someone could get some deal going on that makes it, accessible even cheaper than that from an insurance, from a payer perspective, right? But I mean, the point is that if we can get the Treat Reduce Obesity Act passed, hopefully then the commercial payers won't be able to sort of exclude this as a disease state. I mean, there are places in the country, my colleagues across the country, where you go to the doctor. We have this even in Massachusetts. It's rare in Massachusetts. We're very progressive in Massachusetts, where I am right now. I mean, I'm all across the country, but I actually live and work mainly in Massachusetts or in New England. But other places of the country, you see a patient with obesity and you can't even bill for it. Like you get your 99213 is rejected. Like, just like you have to bill for something else. You have to bill for their sleep apnea or whatever else you're talking about, but if a patient has no comorbidities, comes into an office, there are commercial plans in this country, a lot of commercial plans, to be honest, where potentially it's unknown at the time, but potentially 60% would be my guess, of people that have a commercial insurance, right? Working class people who have a commercial insurance, where they will go to the doctor and then the claim would get rejected and the doctor wouldn't get paid for doing that work, even if they're prescribing, phentermine, topiramate, and lifestyle intervention, and that patient loses 50 pounds, over the course of a year. In working with that person, wouldn't be able to bill obesity as your disease, as your reason for visit and your code, if you don't have another code to stick with it. I mean, that's asinine in 2024. Like, that should not be allowed. That should be illegal.
Yeah, that's like not getting paid for treating someone's hypertension or diabetes. Like, then you got to work the diagnosis to be something else. And it just disincentivizes the system for actually caring for this disease, which is nuts.
My point, right? That's what this carve out does, is it creates this the haves and the have-nots. I mean, it's a bigger equity issue when you really talk about it, right? Because like we said, it's 16, maybe even up to 18 states now that cover obesity medication. Even they've always covered, Medicaid's always been pretty good about allowing you to bill for obesity, and even Medicare, to be honest. Like, Medicare has not had a problem with, like, if you are seeing a Medicare patient and let's say you're only seeing them for obesity, it's quite rare because usually they have other problems that they're coming in for as well by the time they get to Medicare. But let's say that's their only problem. You can pretty much bill for that, and that's not an issue. It's the ancillary services and the medication that isn't covered, under Medicare. And Medicare covers bariatric surgery. They've covered bariatric surgery for quite some time. So it's not like they don't cover, obesity, right? I mean, as a disease state, they just don't tend to include the medications, in addition to the dietitian services and other lifestyle services, which, again, it's rather ridiculous. Think about a Medicare patient. You can refer them if they have chronic kidney disease and diabetes to see the dietitian, but you can't for just their obesity, right?
So the hope is, once this act is passed, hopefully, then Medicare covers medications for obesity. Then your average big name commercial insurance companies will then cover it for others across the country that may or may not be listening to this. That's the hope. That's the hope. Now, what's your over under on this bill actually passing?
So, like I said, it's been I would go so far as to say I'm extremely confident it's going to go this year. Just by the nature of the discussions that we've had on Capitol Hill, especially recently too, meaning there's just a much more acceptance at going every year for 12 years. When we went 12 years ago, it'd be like, yeah, really, obesity? Okay, sorry. We'll sit here and listen to you, but we got another meeting. Can I look at my phone? It was, but now it's like there's such a different approach. Everybody's all the staffers there are like, we get it, we understand it, we know it's a huge problem, we really want to make this work. Of course, the big thing is always it costs too much. It costs too much. It cost too much. But listen, what other disease have we ever had to have a return on investment on and show a positive value? Cost-wise, none. We haven't asked any other disease to do that. We don't not give people dialysis because it doesn't cost, it's not cost effective. We don't do that. We do it to keep them alive. Like, we don't not treat people's cancer because, it's cost effective. No, there's no other disease that we force it to be cost effective before we agree to treat it in healthcare, except for obesity. And so it's not fair. We're like, we sit here and go, what are you guys talking about? We get it. It's expensive. I mean, we get it, right? But the only reason you're saying we have to justify the cost of it is because of this bias and stigma around it still. That still there's this belief that, well, people just behaved. If people just, and that's what you hear everybody talking about right now is getting people off of these medications, getting them off the medications. It's like, granted, yes. It's great to have, no one wants to be on a medication. I tell people as a physician, if I'd never had to prescribe another medication in my entire career, I'd be perfectly fine with it. There are people that get online and say as physicians, we're drug pushers or we're being paid by pharma no, we want people to live longer, healthier, happier lives, right? Like that's our main, first do no harm, right? That's our oath we took. But we want to help people live longer. And that's the main mission of medications and surgery and things is to live longer, not to take a medication, right? But the discussion around getting people off of these medications is also it's just weird. Like, yes, it'd be great it's always great to get off any medication, but it's like, if you have to stay on a medication, why should you feel stigmatized by that? Or because this is what we do. We don't take people off their blood pressure medicine when it gets normal.
Yeah, that's right. That's right. Well, I guess I haven't heard that as much, and not in the circles I've run in, but that there's a lot of talk about just trying to get everyone off of these. Interesting. I did not realize.
At the payer level and at the employer level, because again, the employers have to, most large employers are self-insured. So, they are deciding to give, to provide these services, but they have to manage the cost, right? And you have to manage the cost of all your diseases. We argue, for a long time that, there's a cost benefit here because you actually, don't get diabetes, you don't get, but the problem is that people only stay in a job for a couple of years these days. The average person works for one company. So it doesn't behoove company XYZ to, get a benefit from the patient, like 10 years from now when they're not working there anymore. Right? But I think we all have to do it for each other, right? It's very, it's sort of, like as employer XYZ, I should do it because then, when they come work for you, you're going to get benefit, right? And so if we all did it, we'd all end up getting benefit. It just would be different pieces of the, different pieces of the pie.
And I have heard that actually. I've heard some pharmacists that work for commercial insurance companies say, we would cover it if everybody else did too. Because to your point, they don't want to spend the money and then they leave and all of a sudden the other company gets the benefit, long-term benefit from the medicine they paid for, is the argument that at least that they're.
Exactly. Right. And so I think, but there's a lot of other expensive medicines and expensive diseases, right, that we cover, and again, I'm not saying we should, we do need to have some, I liken it to back in the day of antibiotic stewardship, right, where, we recognized we were giving out way too many antibiotics, right, because patients would come in with a sniffle and we'd be like, here's your antibiotics. And then we realized, we're getting all these like resistant, bugs. And so we need, we also need anti-obesity medication stewardship today because, we don't have enough. And, people keep saying, well, why can't they make more? The drug, they're holding out. They're just, no, there's 140 million people in the United States alone with obesity. A little while ago, Novo Nordisk at one of their earnings calls announced that they're putting 25,000 new patients a week on medication, right? If you do that math and you assume that Eli Lilly can do the same thing, this is for GLP-1 alone, not the other medications, but just GLP-1. If you do that math, it would take 58 years before we could treat all 140 million Americans with GLP-1, assuming that the production stays the same. Now, the production is not going to stay the same. They're building new plants. They're increasing capacity, so we're going to have a lot more capacity. But it's just, there's a lot of people to be treated in general. And so we need to treat them with everything we have available and figure out, who's going to, be successful with this medication, right? And who's going to be successful with this medication so we can save this medication for people who might need it, right? So that's where we're at. And we've never been very good at that in United States healthcare, unfortunately.
Well, and to your point of, if there's that many people that could benefit from this medication, but obviously not a majority of them can access it. A lot of them are trying to find it in other ways. And this is what I really am excited to ask you about, is when your local compounding pharmacy says, oh yeah, we have that, and we'll add some B12 and whatever they want to put on there, and it's on a billboard, that's really misleading to patients. So talk a little bit about educate the audience on the problem you see because of the limited access, where a lot of patients are taking these kind of experimental medications.
Essentially, right? And that's the big thing, what you said there, is that the real issue that we have with it, and we just published, it's just in preprint right now. So, it's available online on Obesity Pillars. Our journal of the Obesity Medicine Association is called Obesity Pillars. It's open access, so anybody can access it online. It doesn't require a subscription. And we have a publication we just put out a couple weeks ago on frequently asked questions around our compounded peptide statement. So we made a statement, it's probably been a year ago or so now, around this compounding process, because we made the statement because we are concerned about it. We're rightfully concerned about this idea of first do no harm, in our oath that we take as clinicians, right? We all want people to have more access to effective treatment. But the question is, what is the risk, right? The idea is a compounded medication, the API, the active pharmaceutical ingredient, there's no generic semaglutide. There's no generic tirzepatide. There's no place that is FDA approved to produce semaglutide as a generic component to go into the product, right? If you're making, there's been some arguments that we use compounding a lot in shortages, say, for example, with heparin in the hospitals, right? And we need to compound the heparin and then the hospital gets it, and then the hospital gives it to people and they charge their insurance, right? It's all still, you're still getting it in a setting of emergency, but you're getting it hopefully in the best possible setting you can get it in, right? And it's covered by your insurance. Now we're saying to people with obesity, well, we don't care about you enough to warrant treating you, but you can go over here and you can get some of this stuff and it might be okay. It might work. Is might really what the word that we want to use when we're talking about treating someone with a pharmaceutical? Why do we have an FDA? I thought we had an FDA so that we didn't have to deal with it's probably okay. Why do all these studies? Novo and Lilly spent years developing these molecules and millions of dollars, billions of dollars potentially, researching them and showing that they're safe and they don't kill people, right? And now we have people copycatting the API. And granted, I'm sure there's smart people who can copycat the API. Don't get me wrong. Smart chemists who can make it in a lab somewhere. But it's not being controlled in any way, shape, or form to come over to the US. And then that's going into these products. And then, when you're doing something for cash, a lot of people, you're going to cut a corner here, cut a corner there. Do you test every batch, right, that comes over? If you took semaglutide from an API manufacturer of questionable ethics, questionable processing, right? But you brought it over and you tested it and you assured that it was, 100% safe, and it was semaglutide. It was the exact same stuff as the molecule, looked the same, and then you put it into something, and then again, we were getting it out to people in an emergency situation via their insurance. That would be there's a different motivation there than we're going to put it into stuff and send it out and we're going to charge cash for it. Because I used to work for Procter & Gamble, a very large consumer products, group, company in the world, right? Everything we talked about was, how can we get a bigger margin? Do we really need to have that in there? Can we add this in can we change this a little bit, so that it's still the product, but, still effective, but maybe cheaper, right? I mean, and that's going to happen. And then people are going to get hurt. And there's nobody, and there was an estimate that 2 million people are taking these things now, and that's different than, 100 people taking them because we have a heparin shortage.
Yeah. And 2 million people, I mean, it's going to be interesting to see the retrospective look on, hopefully it's fine. I have my doubts, but
that's not the way we work. I mean, I get it. If I still think, again, I say I said in a statement before, that we should do something. We need to come together and sit down together, just like COVID, and figure out, like Operation Warp Speed, right? And figure out, Operation, get people treated for obesity. And figure out how to do that. We could do that. We could sit down and attack this pandemic just like we did the other pandemic. And that's really what we need to do. I mean, whether that's figuring out how to bring it in a way that is safe and effective, where people are registered, people are researched, right? I mean, according to the FDA website, 9 people have died. Relation to compounded products like this, right? And whether or not it was actually the cause, you never know. I mean, it's a report feature where, a person would report, or the family would report, or a doctor would report that the patient died and they were taking this, right? I mean, whether or not that was the cause or not of the death, that's hard to know. But still, the point is that this is not something where people need to die for, but we're okay with that, I guess.
I'm surprised too. There's no legal issues with Eli Lilly and Novo Nordisk on these. Maybe they're just so many to hard to.
Well, that's the thing, is there's a shortage, and now what was just announced this week in Eli Lilly's earnings call, if you're aware of that, is that they are going to launch. They've announced that the shortage is over, essentially, and so I believe that there's a 6-month loophole potentially, where there's 6 months still but I just don't think people are going to be able to do it at the scale they're doing it today, at the marketing that they're doing it today. I know Hims and Hers has said that they feel like they can still compound even after the shortage. I mean, you can, as you mentioned, you can compound in the relation that you're making a special product for a special person because you're allergic to something, you're allergic to the dye, let's say, in a formulation, and then we can make you that compounded product, right? Because you are allergic to it, right? But making it at scale for 1 million people and claiming that they all need B12 in their medicine, I mean, that's a little bit far-fetched because we don't have any clinical data to suggest that's helpful.
I agree wholeheartedly. And I love the passion. I love how much you genuinely care about the community and doing the right thing. And I think I'm guessing that also was a motivation in your new company that you're with Knownwell. So I'd love to hear more about what led you to start Knownwell and a little bit more about how you guys are helping this community.
Yeah, so it was really my co-founder, Brooke Bayorski-Pratt. She's a patient with obesity. She has obesity her whole lifetime and has felt this, the stigma, the bias against the disease, having to, really, moving around the country. She was working for one of Berkshire Hathaway's, Warren Buffett's companies, and, would go move to different places of the country and need to establish care again and wait in a line, that's 5,000 people long to get into the weight center. And when she just needed a refill of her medication for obesity, trying to find a doctor that would be okay with that, figuring out online, is this doctor gonna, berate me and tell me I should just, eat better, even though I've been trying to do that for 20 years, versus give me a refill of my Saxenda or my Wegovy or whatever, medication I just need refilled. So she really felt that. And one day she was feeling that in particular. And she said, why is there not a special clinic, a special place, where people with obesity can get the care they want, that they want, right, for them, even if it's that they don't want to lose weight, which is acceptable, right? I mean, meeting a patient where they are and understanding their, what their goals are in a shared decision-making fashion is really what we should be doing with any disease state. We have patients with cancer that don't want their cancer treated, depending, on their circumstances. So we have to understand, where patients are at and what they're trying to accomplish, and doing that in a non-stigmatizing fashion. And so she came to me and we started meeting, we started talking. I was mostly kind of advising, if you will, as a national leader in obesity treatment. And And then, we determined that, hey, there was enough of a desire for something like this, doing focus groups and things with patients, that we built it. And we think, that it really is, a comprehensive longitudinal approach is what we need for the treatment of obesity, that it shouldn't be sectored off into a little sector, and pigeoned off into a corner of treatment, that it should be, comprehensive care delivered, holistically throughout your lifetime, which is also why we're treating adolescents as well.
Wow, that's amazing. So how long have you guys been seeing patients?
We've been seeing patients since March of last year. So that's 2023, right? Yep.
Awesome.
We opened our doors in March of 23, and we got an initial seed funding from Flare Capital. And then we just completed our Series A with Andreessen Horowitz and A16Z. And we're just moving along and hoping to really be able to scale this treatment, both in a virtual and in-person format. We have in-person clinics, so our differentiator is we're what we call ourselves click and mortar. So we have virtual care. Some of our patients see us only virtually, whereas others want to be able to come into the clinic and have that clinic to welcoming atmosphere to care for them specifically.
That's amazing. Well, congratulations on all of that. That's really exciting. And I love the mission, and hopefully provides a lot more access to patients who need excellent care. Where can people find out more about Knownwell, or even find out more about you and all of the amazing messaging and information you're sharing?
Yeah, so it's just www.knownwell.co. So not .com, but just .co. Apparently .co is cheaper than .com.
Yeah, I get it.
Knownwell.co, and please, feel free to come and reach out to us. We have a blog a little bit, and that's where you'll find us.
Excellent. And a lot of amazing information that you share. Love the passion. As I said, I always learn a lot listening to you as a clinician, fellow doctor. So it was very fun to talk to you. But I have one last question. Because you deal with doctors across a wide spectrum of practice settings, what is one thing that you wish all doctors knew about obesity medicine?
I will say that, to really portray to the patient that it's not their fault. That this disease, the patients with obesity feel like it's their fault. And that's because society has sort of said that, right? And that it's not just about eating less and exercising more. We all need to make lifestyle changes. I mean, the world we live in is predominantly obesogenic. It's stressful. It does not promote health and well-being by nature. Our normal world with all of our phones and alerts and, everything going on, right? So just really understanding that this is not the fault of the person, and being open to that, and being open to, helping them with either a treatment or referring them to someone, who is knowledgeable about treatment, if that clinician isn't knowledgeable.
Excellent. Well, Dr. Angela Fitch, thank you for joining us on the podcast today, and I'm sure we'll talk soon.
Thank you so much for having me. It's a pleasure.
Wow, that was great to get to talk with Dr. Fitch. Lots of questions that I had, and I think lots of interesting, not only practical nuggets on how to manage it, but on just a history of how this has all worked, how it's worked, not only from the insurance side, but also legislatively. I don't know, Ned, is there any salient points that you took away from that especially what's influenced how doctors can actually practice?
Yeah, absolutely. I mean, I think something that really resonated with me, and I'm sorry I wasn't there getting to interview Dr. Fitch right alongside you, Michael, but it was wonderful to listen to, was how obesity has almost been kind of ignored, or the ability for doctors to treat it has almost been left out of recognizing obesity as a distinct standalone disease or disorder. And so as a result, it's often kind of gotten in the way of itself from a policy standpoint, that there has not been collective action or even, frankly, a unified approach to reimbursement for the treatment in obesity medicine. And reimbursements drive behavior, unfortunately. And so you end up with this very patchy approach to it of certain plans cover this, certain plans cover this. Even just almost immediately after the interview, the New York State the New York State Public Employees Unit said that they're no longer covering Wegovy or Ozempic. That just happened, I think, a day or two after. And so, again, there's just this really chaos in the whole space of obesity medicine and how it's being approached from all these different employers and health systems and physicians and even patients themselves.
Yeah, I'll be interested to see, we talked a lot about it, but how Medicare ends up playing a part in this, and where Medicare goes, the private insurance companies go, and where they go. It affects how a lot of people are able to access this medication. So I know she's actively lobbying. There's a lot of other doctors who are actively lobbying. And it sounds like finally there's maybe a little bit of bipartisan support in this as it's become more recognizable. There's more awareness for treatment. People have had more family members have successful treatments, et cetera. So maybe there is some bipartisan support to get something done.
I think it really will require bipartisan action because, frankly, the amount of money that is being talked about from a policy standpoint to cover these kind of treatments. But at the same point, the disease itself is not partisan. It affects everybody across the country. It's one of our most significant public health challenges right now. And so it's going to take large collective efforts to try to turn the tide, even, negotiate with the drug companies if we're buying in bulk, like really structurally changing the way in which even the federal government exists to provide public health for its constituents.
And then there's, I think back to our episode with Mark Cuban about just transparency and pricing and letting the end consumer, the patients, understand the pricing and where the money's going, insurance and pharmacies and PBMs. And it's a big push, obviously, with these medications as well. So lots of great information. Super thrilled we were able to talk to Dr. Fitch, who, again, is probably the nation's leading most expert on this topic. It was great to talk with her today, and appreciate you joining us, and we'll talk to you next time.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. And the next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.